Keep forgetting. Good. All right. So we're gonna. So it's a lot of material, but if you look at it simply and try to remember the basic tumors that that can be seen in each layer, it tends to simplify it. All right. A lot of times the treatments are almost similar. Remove, biopsy, histology, treat, um, you know, get a clear margin, or if you didn't get a clear margin, you cryo, or you go for chemotherapy. So treatment is simple. It's just the hardest part is just to try and remember the different names in each area. All right, so let's go. The other thing is that exams coming up soon, and I want you to be able to feel comfortable to describe your photographs. You're not be, this is what exactly what you're going to get in your exams. You're going to get pictures. You're going to have to be able to navigate around them. You can't, there are going to be pictures that you may have seen or you may not have seen. So you have to learn to navigate yourself around these photographs. All right. So let's hope at the end of this lecture, you'll feel a little more comfortable. All right. But you got to talk to me. Yeah. All right. So we're going to classify them. So like everything else, you have malignant, benign, metastatic, and congenital. So let us start at the eyelid. So, as I said, this is a list of the most common eyelid lesions that you would find, the malignant lesions that you'd find. So, basal cell carcinoma, squamous cell carcinoma, sebaceous gland, malignant melanoma, and Kaposi sarcoma. All right, so basal cell carcinoma, it's derived from the basal layer, as it says, basal layer of the epidermis. It's the most common malignant tumor of the eyelid, and it's mostly found on the upper eyelid, more common in whites, usual UV exposure, and later age of presentation. So what I want you to do now is I want you, who is a brave soul today? Who wants to take on this slide? I'm gonna call on you all, So let's see. Let's see. Strachan. Strachan. Open up your microphone. Zaria, am I getting the name correct? Zaria. No, Zaria having issues. All right. Simone. Simone.
Good
Yes.
morning.
Good. Good morning, Simone. I hope you're awake. All right. So let's start. Describe this photograph for me. This is a photograph of.
It's a photograph of the realistic left eye. Um, and I'm seeing the erythema on the lower eye, and ulceration.
All right, so first of all, the first thing you're going to do, so the first thing you did was good. You identify that this is the lower eyelid. Next thing out, so you're going to be imagining that I am on the phone. I'm not looking at this lesion with you. So the next thing you're going to tell me is where on the eyelid. Is it in the middle of the eyelid? Is it at the junction of the medial two thirds and the lateral one third? All right. So what do you think this is?
It's at the junction of the medial 2/3 and lateral 1/3.
Right, good. So therefore, so you see now I know exactly where you're at. So you're gonna tell me about the margins. How does the margins look?
The margin looks kind of regular,
Irregular, and
irregular.
see,
Okay.
and it's rolled. See, it's rolled. See, I giving you that feeling there. Mm-hmm. See, I doing it with my finger. Mm-hmm. So see, it's rolled edges. Yes. So the edges are rolled inwards, right? And what is the base? and what happened here?
It looks like an erosion or ulcer.
Yes, so there's an erosion, and the base of it is erythematous. See how easy that was? And then we come over here now, and what is this that we're seeing here? How would you describe this lesion at the
Mm,
medial aspect below the punctum? See, so you're going to be using your anatomy so that I can see, I can tell where you're at, right? So what we're seeing here.
darkened area.
So it's a hyperpigmented area, yes. So we could even say it looks scaly, it looks, it's irregular, and it's a circular lesion there. So this is a suspicious lesion, all right? So we're definitely seeing a definite erosion here, and we have a suspicious lesion medially below the punctum. See how easy that was? Thank you, Simone. All right. So so the manifestation, so we saw the one that we saw was ulcerative. It can be nodular, so this pearly lesion here, and you can have vessels. It can be you can see some more rolled edges here, darkened, and it's ulcerative here, and everything just looks indurated. Okay, so it may be pigmented, but luckily intraocular and metastasis are rare. All right. So so let us look at the two lesions that we had so far. So here we have a ulcerative lesion with rolled edges. Here it can be nodular, it can be indurated, and we have these pigmented lesions as we saw in the other one. Okay. And as we said, excision treatment is simple. You excise it, and you can if you're not, so for this you'd want a wide lesion, you're a wide margin here, so you'd want to ensure that when you're removing this, you're clear, you have a like almost a 4 millimeter margin of clear tissue. So and if you wish, you may cryo the edges or you may laser the edges so that you sure that there's no recurrence. All right. So here we have another one where it's the rolled edges, the ulceration. Sometimes they call this they call it a rodent ulcer because this can get so large if we leave it untreated. All right. Squamous cell carcinoma. So this is now the squamous layer cells of the epidermis. So it's a malignant tumor of the squamous layer. It's less common than basal cell carcinoma, higher chance of metastases and local spread to adjacent structures. So it's commonly found on the lower lid, high risk, as we said, fair skin, UV exposure. So what I want you to understand here is that um, oftentimes when we see a lesion on the eyelid, we can't be 100% sure unless we've been following it over a period of time what it is. So don't expect, don't let anybody intimidate you into thinking in your exams into thinking that yes, you must know if it's a basal cell carcinoma or if it's a squamous cell carcinoma. You have to learn, you have to be able to put your differentials, and then you're going to decide how it is, what is it that you're going to do. And of course you're going to excise and or biopsy and send for histology. That is how you're going to know what it is. All right, but you must be able to describe your lesions. So here we see a very darkened area. The edges don't look, the edges, the what would trigger me into thinking that this is a squamous cell carcinoma? The edges don't look as rolled as the other one. There's more pigmentation here, and we see the lesion. let's go back a little bit. The lesion seems a little flatter, okay? It seems a little more superficial to me. But as I said, if you were to say to give a differential of basal cell carcinoma or squamous cell carcinoma, nobody would fault you because you go on to say how you would determine what it is. All right. So as I said to you, a lot of times you know it's a squamous cell carcinoma because you've been following the lesion for a while. So, but in the cases where they just develop de novo, hey, you're on your own. You have to be, as I said, biopsy and find out what it is. Your history is important. If there's a history of radiation, yes, you know, most likely you're thinking of a squamous cell carcinoma. And as I said to you, the if you've been following pre-existing lesions, so like here, where there's keratosis, actinic keratosis. So you've been following this lesion here, this indescript lesion here, which is reddish and raised nodules, and you've been looking at it for a time, and you see that it is extending. Then therefore, you know you have to biopsy this area and see if it's indeed get developing to form squamous cell carcinoma. And in a patient that has xeroderma pigmentosa, you know you have to be looking at these lesions to see if any of them are increasing in size or looking that they're becoming ulcerative, and and you need to biopsy these lesions. And in Bowen's disease, you have this, you definitely want to biopsy and see if there's any risk of it becoming malignant. So how does it manifest? It looks nodular with irregular margins. It can be indurated with hyperkeratotic plaques. So there we see a plaque forming on here. Um, it could be a papillomatous lesion here, and you so these would be very suspicious. And if you saw a cutaneous horn, you'd be like, okay, I don't think I'd have to ask you twice to that these things needs to be removed and sent off for testing. All right. Treatment, excision, radiation, cryotherapy. So here we have another plaque-like lesion. Um, so so everybody, so you're getting you're understanding how you're going to approach these lesions. I hope. Any questions before I leave basal cell carcinoma and squamous cell carcinoma, because these are the most common types that's going to be presented to you. Nope. Okay, let's move on. All right. So
Doc,
these are who's this now? Marie? Yeah, let me go back. What you want me to explain, Marie?
so the manifestations are basically what happens to the um, carcinoma if you leave it without treatment.
No, somebody can present like this. Somebody can present like this. Not everybody. You'll be amazed that there are persons who have lesions like this that are presenting to you for the first time. Um, it as I said, you could. So remember, I said here it could be de novo. It's the first time it's presenting, and there's nothing in the history that would help you. Okay, or you could have pre-existing lesions that you've been following. But yes, somebody can present to you looking like this. But in a case like this, I I would um I would just looking at it initially, your differential would have to include basal cell carcinoma, squamous cell carcinoma. Understand?
Okay, thank you.
Right. But remember, as I said, there are certain features that are pathognomic of a basal cell carcinoma. The rolled edges. Look, and the little crater that is forming, that is pathognomic of an or the pearly light lesions. Okay, those are pathognomic of basal cell carcinoma. Whereas the plaques, the plaques and the papillomatous lesion, the cutaneous horns, if you see this, you know that it is squamous cell carcinoma would be your first differential. But as I said to you, even in the best cases of persons who deal with this every day, they still have to rely on their histology. All right. Sebaceous gland carcinoma. Now, it's a malignant neoplasm arising from glands. So it can arise from the meibomian gland, the Zeiss gland, the sebaceous glands. It's very aggressive, but thankfully it's rare. It has a high mortality rate with high recurrence. Most common site upper eyelid, upper eyelid. So what we call this is the masquerade. So you may think that this is a chalazion. You may think it's just blepharitis. These are patients who have had multiple treatment for blepharitis, chalazion, all other things, and they keep recurring. So these are patients that you have to take a very good history from. So you're looking here, you see a nodular lesion, the plaque-like thickening of the tarsal plate, loss of lashes. As I said, it's a masquerade syndrome. It can mimic many things. So right here, you would see what we look at as this would could someone could think it's a large chalazion, okay? But what it is, if you see this, you would definitely have to have a high level of suspicion. So you'd want to remove this, send it for histology, and if this is so large, you may have to even do radiation. All right. So remember, I said treatment for all of these are pretty easy. So this presenting this first time this is presenting to a doctor, more than likely you would think of it as blepharitis, meaning an inflammation of the lid margins. But as you look at it more carefully, it is nodular. There's loss of lashes. So these are the things that would cue you in that something ominous is happening. Malignant melanoma. So these you can't miss. It's an invasive proliferation of malignant melanocytes. So it's 1% of eyelid tumors. It's 12 times more common in whites than blacks. So what you're seeing is flat macular lesion with irregular borders and pigmented. So right here, you see this large pigment area, but if you look at it, so you've asked me, why is this not a mole? Why you don't think this is a mole or a nevus? But if you look at the lid margins, you see the irregular borders of it. You see, it's very irregular. So you wouldn't expect a nevus. A nevus would have smoother, defined margins. But once you're seeing this irregular borders here, you get very suspicious. So here it looks more like macular lesions is elevated. And when you look down here, you see a satellite lesion. So you know this is an indication that something is happening. All right. Treatment, cryotherapy, excision, cryotherapy. So and look at this lesion again. You see these nodular lesions. There's no way you can say this is a nevus. Okay. But you'd be so surprised that someone will be sitting at home with this and just saying it's a black spot that's getting bigger. Kaposi sarcoma, we hardly see this much anymore, but in the early stages of HIV, yes, we saw a lot of it. Um, so this would be your differential diagnosis with your melanomas. So, but of course, you would be able to differentiate it from your history. So this is a neoplasm that affects the cutaneous or mucosal surface of the eyelid. It's commonly seen in AIDS patients. It's highly vascularized, purple or red nodules. This one I could understand that you would give me a differential diagnosis of a melanoma. You'd want to differentiate, but this one you can see how erythematous this is. It looks almost purple. So but you would have known from your history that you would be think you this would be high on your list. All right. So treatment while excision, you need to test the lymph nodes cryotherapy. All right, so that's the eyelids done. Any questions on the eyelids? Okay, good. All right, so let's go now to the conjunctiva and the cornea. So we have squamous cell carcinoma, corneal intraepithelial neoplasia, which we call CIN for short. So risk factors: advanced age, UV exposure, cigarette smoking, history of squamous cell carcinoma of the skin, head and neck, fair complexion, the usual story: AIDS, HPV 16 and 18, xeroderma pigmentosa. So let us look at what we're looking at now. So the question you're going to ask me is, why is this? Why do I think this is a squamous cell carcinoma and not a pterygium? So Daniel, Drix, Daniel, sorry. We have two Daniel. We have Drix and Twiddle. Okay, Drix.
Hey, Doc.
Hiya. All right. So look, tell me about this lesion. How would you describe this lesion?
I would say that it's a erythematous lesion on the can't really tell. Well, this one looks like the one on the left looks like the medial aspect of the eye, and it seems to be very vascularized.
Mm-hmm.
And raised.
All right.
It seems like a raised area.
Remember what I said? Remember, I'm not looking at this picture with you. All right. So you're gonna tell me where it is on. You're gonna tell me anatomically. So that's so you. So that you took the bait. You jumped straight to the lesion. You didn't tell me where the lesion was. All right. So that's what I'm saying. Calm down. Take a deep breath. So you didn't know I was gonna pick on you. You didn't know it was your turn. So you have to just take a deep breath and say, where is this lesion? So it's extending from the sclera and it's involving the limbus and it is encroaching on the cornea. See? You see, you miss all them three lines there before you start talk about the lesion.
Well, I
Okay?
was getting there.
go through drinks. All right, go ahead.
Yeah, so the lesion is encroaching into the limbus and um is can I say it's bordering on the pupil?
No, because remember, this is the cornea. The pupil is inside the eye. So,
Okay.
or you could say it's obscuring, but you can't say it's bordering on because I may think that you think it is on the pupil. You
Okay.
understand? But the lesion is on the cornea. So it is a common mistake. So I'm glad you mentioned it. This is a common mistake that is made all the time in the exams. You can't, so you have to your terminology. So that's why it's the most important to talk to me, guys. You can't say there are certain things. If you say it's on the iris, then you're indicating that the lesions is on the iris. Okay, so if you're saying that, someone would say, okay, this is encroaching on the iris, automatically you get it wrong, because even though it's the iris you're looking at, it is not on the iris, it is on the cornea. But you could say that it is almost, it is approaching the pupillary area, or it's encroaching on the pupillary area, okay? Or it's encroaching on the visual axis. Those are the terminology that I want to hear from you guys. All right. So, in other words, you're saying to me that a lesion like this may eventually reduce visual acuity. All right, Hendrix?
I'm with you.
Okay. All right. So there's something else you need to tell me. What do you think about the blood vessels?
Um, Seems to show some signs of neovascularization. Or
Mm,
they're very engorged.
they're engorged, and you see, I'm giving you hints here. See me tracing it
And
there.
torturous.
Yes, it's very torturous. Yes, it is. It is. All right. Thank you. So let me hear Twiddle. I like when I have these names. Twiddle. Twiddle.
Hello.
Hello, Twiddle. How are you? All right. So look at this lesion now. How would you describe this lesion? Oh, sorry. Let me not do like Drake's. Yeah, describe the picture.
Well, there is a picture of an eye with, what do you call this? Redness in the sclera. Looks like blood vessels.
All
Um,
right. So Twiddle. Remember, we're in a medical school now. So we
what?
can't say redness. Why would
Erythema.
you say redness?
What was that?
You can't say redness. You must say
Erythema.
yes, yes, Twiddle. Yes, yes. Erythema. Yes, so it's erythematous. Mhm.
Right. And um, on the lateral, I don't know. I can't say that. Am I?
Yeah, yeah. Mhm.
On the lateral border of the cornea, there is a mass
Mhm.
that seems well circumscribed. No. Yes, is it?
Yeah, you can say that. It is fairly well circumcised.
A well circumscribed mass with erythematous spots.
Okay. So what about, so where is it? Where exactly on the cornea is it? Is that 12 o'clock? Where is it? Is that the limbus? It's in the middle of the cornea?
I'm gonna say so. Hold on. 5 o'clock.
Yeah, I could say 5 o'clock, but 5 o'clock where? At the limbus, encroaching on the cornea. Okay.
Yes.
In this patient, the pupil is dilated. So yes, it appears to be encroaching on the dilated pupil. All right. And what did we say about these blood vessels? How did Drake's describe these blood vessels?
I cannot recall.
Drake's just told us. Drake's, tell her.
The
Drake.
blood vessel torturous.
Yes, right. They're tortuous. Twiddle, open up back your microphone. So they're tortuous vessels. There are multiple tortuous vessels. All right. And then when we see a very large vessel like this, we often call it a sentinel vessel. So hopefully I'll find another one that only has one vessel, one large vessel. All right. Okay, good. All right. So treatment depends on size and location. We're going to excise it, cry the borders. Oftentimes we can't excise this area. If we were to excise all of this area, you're literally removing almost half of the cornea and this limbus. It's very hard for eye to survive that. So a lot of times we have to give them topical treatment. So we treat them with topical antimetabolites like mitomycin, 5-fluorouracil. Sometimes we give radiation, but most of the times we treat them topically. And we shrink it, with the antimetabolites, and maybe we can excise it, and then we always clear the borders. If it's really large and it's extending into the eye, we have to enucleate the eye. And if it's extended to the lymph nodes, so you always have to examine your lymph nodes. You definitely would have to remove the entire contents of the orbit. So enucleation is when you remove the actual eyeball. But exenteration, you remove the muscles, the fat, everything that's within the orbit. You try to clear that orbit, all right, so that you don't have further spread. So Goodridge, Raquel, Goodridge, wake up! You having breakfast?
No, doctor.
Okay, good. So tell me about this lesion. Tell me about this picture.
So I'm seeing a hypopigment, not hypopigmentation. Um, but I just
So this
see
looks to me like a plaque. I would say this is like a plaque. Huh?
okay.
Yeah, it's like a plaque, right?
So I'm seeing a plaque extending from the, I would say both from the upper to the lower cornea.
So
But
and so here now it would help if you told me clock hours. So this is like what time? What clock is this?
from 12 to 6,
Huh? 12 o'clock? Uh-huh. And going down to
6, 7.
right. Okay. So yes, so and it is encroaching onto the on the cornea, and it is almost encroaching on the pupillar margins, right? And you see a large vessel here.
Yeah.
Okay, good.
The
Thanks.
sentinel, as the
Yes, this
sentinel
would be a sentinel vessel. Yes, yes. Okay. All right. So so pretty much that was your squamous. So these are the most common that you would see. All right. However, you may also see the other lesions on the conjunctiva that will perplex you will be the melanocytic tumors. So then the problem is what what is what is dangerous versus what is benign. Okay, how are you going to differentiate it? What are the features you're going to be looking for? So when we're looking at the melanocytic tumors, sometimes we see primary acquired melanosis, which is a flat patch of brown conjunctiva. And we must have seen this in persons, our relatives, or even on our own selves. We see them a lot in dark skinned persons. Just an area where it just looks brown. And everybody like, oh my, how can I get rid of this? My eyes don't look nice and white. All right, so you're gonna get it. You can also have a nevus, a melanocytic conjunctival nevus, which is a dark brown elevated lesion of the limbal conjunctiva or caruncle. So this one is here. But nobody needs to tell you that this now looks alright compared to this. So someone may have a combination. It can have the flat patch, or they can have the elevated lesions that are very suspicious that needs to be removed. So once you see these elevated lesions here, this is very suspicious. And then oftentimes it may be amelanotic to try and confuse us. All right. So so what is it that you're going to tell someone? How are you going to so you're gonna have parents, especially parents, coming to you and that there's a brown spot in my baby's eyes and I don't like it and it's getting bigger. What are the things? What are you gonna be looking for? So of course you're gonna say, okay, I think this is a nevus. just like how you have spots the rest of your body, but we're going to be observing it over time. Okay, so we're looking for discrete dark brown to yellow lesions, less than 1% risk of converting to a melanoma. So you're pretty safe in saying that, yeah, you can watch this. So you're going to be looking for the color, location, size, increased vascularity. So these vessels, if I see these vessels getting tortuous, I know we're in trouble. If the lesions start getting larger, yes, we have to watch it. However, sometimes the lesion will get larger depending on hormonal changes in your body. So sometimes at puberty, if you got pregnant, sometimes at menopause, these lesions can change. All right. But yes, you're going to tell them, you're going to observe it. However, if they're insistent, yes, they can be removed. However, now let's see who I'm going to talk to now. Savannah. Savannah. Savannah, Savannah, Savannah. Yeah.
Morning.
All right. So, hey, tell me about A.
Okay, so this is I see on the sclera on the right side of the eye there is hyperpigmentation.
Hold on. Stop. One stop. Stop. Savannah. All right. So there are terminal villi, medial, temporal. We like those vision. We like those terminal vision. Okay.
Okay. Okay,
Yes.
so from the medial aspect of the sclera, approaching on the limbus as well, there is hyperpigmentation, hyperpigmented macule.
Right.
So it's on the limbus and it's approaching the cornea or the border of the cornea. The
Okay. Right. And the
it's at
margin. Mm-hmm.
margin, it's irregular
Yes, it's irregular.
and it's at 9 o'clock.
Uh-huh. And
There is a dilated vessel.
what we call this a sentinel vessel. Okay.
Oh yeah, sentinels.
One large, yes, so there's one large dilated vessel. Thank you.
Yeah.
Okay, so looking at this person when we examine, we see a flat area here, a flat pigmented layer here, and this area doesn't necessarily look threatening. But when you see this lesion, when you see this elevated area, definitely you know that we're in trouble here. So we'll look at B. So we're seeing a erythematous area here along the border here. So it's all of here is erythematous here. And so remember in our picture of our nevus, there wasn't much erythema going on. Okay. So when you see this and you see these engorged sentinel vessels, yes, we're getting very suspicious here. And look at these large lesions on the limbus extending onto the cornea. Definitely something is happening here. This person needs to be referred immediately. All right. So treatment, um, excision, cryotherapy, radiation. Okay. But remember, there's always a risk. Melanocytic tumors they can also metastasize. So we have to make sure we check our lymph nodes, and make sure the person we're not just treating the eye, okay? Must always remember the patient, it's a patient, so you have to ensure life first, okay? Okay, so we're going to the rare. So we've pretty much done the main ones that we're interested in. These are the ones you have to remember: your squamous cell carcinoma, your melanocytic tumors. Those are the ones that can kill the patient. Okay, so you have to have the eye out for those. And the problem with the melanocytic tumors is that you have the ones that are benign, and you have to watch them to make sure that they're not going to transform into malignant melanocytic tumors. Okay. All right. So lymphoid tumors. This involves the lymphatic tissue of the conjunctiva. It's rare. It's often seen in middle-aged to elderly. It's a pink subepithelial mass of bulbar or fornix conjunctiva. Treatment: topical or oral steroids, radiation. So we're just looking at this really fat pink mass that we're seeing here. A lot of times, you think it's probably the lacrimal gland, because it's just so big and fat and pink. But usually, you have to biopsy this to know what it is. It just looks very non-specific, as you would expect of a lymphoid tumor. All right, Kaposi sarcoma of the conjunctiva. If you saw this, yes. So let us see Natasia, Natasia, Haber. How should you pronounce that? The H silent. Is it Haber? Is it Natasia? Are you going to let me crucify your name? You're not going to tell me how to pronounce it? Apparently, Natasia is sleeping. Okay, let me go for another name that I can not pronounce. Aladum. Chetachu. Aladum. No? You're not going to tell me how to pronounce your name. Yes.
Good morning, Doc.
Good morning. Tell me how to pronounce your name.
Chetachuku.
No, Sam, I can't manage that. What's the surname?
Aladum.
All right, I can do that one. Yes, Miss Aladum. Yes. So tell me about this picture. What are you seeing?
It looks like hemorrhage.
Mm-hmm. So a subconjunctival hemorrhage would be a differential. But then you look here and you see these. What are you seeing here? You're seeing some discrete.
Mm, uh, like discrete single lesions, small.
Right. Small lesion. So this is what would indicate to you it is not a subconjunctival hemorrhage. It is actually a mass. So yes, a differential. Yes. So it is a bright red subepithelial mass that's here, and then you have other lesions here. Okay, so this is so
Okay.
same. So this would start a conversation in the exam, and you'd want to they would ask you how would you differentiate it, or what are the features that would make you think it's not a subconjunctival hemorrhage. Okay.
Okay. Thanks.
All right, great, thanks. All right, so it's as we said, it's found in AIDS treatment. So you want to excise, definitely cryo, radiation, chemotherapy, or you may want to inject an antimetabolite like interferon. Okay, so as I said, looking at here, this is definitely not a subconjunctival hemorrhage because you're seeing all these discrete little lesions all over the eye. All right. So, a uveal melanoma. Okay, so now we're going inside the eye. It's um it's it's a primary acquired malignant neoplasm of uveal melanocytes. So where is the uvea? The uvea literally it's the iris running all the way around to the back of the eye to the ciliary. It's right there. It's coming off. The ciliary processes are coming off. The ciliary body is coming off. So the uvea is including the iris going all the way back to the back of the eye. Okay, so these to the choroid. So it is it is an expansive area that can be involved in a melanoma. So you can either see it at the front of the eye, or you can see it in the back of the eye. So you may have to dilate the eye to see it. So in this picture, it's a dilated picture seeing a lesion arising from the choroid. Why you know it's choroid? Because it's so dark. All right. And if it was a lesion, that's the only dark thing that's around the back of the eye. All right. Because you have the sclera, you have the choroid, you have the retina. So the only dark thing that is full of vessels is your choroid. All right. So you can, so when if you dilate the pupil and you see this large mass, you know it's query, it may be a uveal melanoma. um Oftentimes it can, as I said to you, because it's such an extensive area that it can occur. You can often see it sometimes protruding um through the sclera. Now the question is, how do I know this is a lesion? Let me see who am I? Jessica,
Hello.
good morning. How do I know that this is not a lesion of the conjunct? It's not a lesion on the sclera or the conjunctiva. It is actually coming from within and burst
Um,
through the sclera. Look.
I
Mhm.
think because you could see that there's no like mm, it looks like it's covered by like kind of the opacity of the sclera, almost like cloudy. Um,
Right. And look at, see, I always help you now, and we're helping you exactly
oh,
now. See,
sorry, right. And you could actually see the sclera on top of
the blood,
the
yes, the conjunctiva and the blood vessels are,
blood
the blood
vessels
vessels
all
of the
over
conjunctiva are going over it. See?
conjunctiva. Okay.
See the blood vessels? They're
Yes.
actually, yes, it's actually, you see,
Covering.
like it's climbing over, covering the lesion.
Right.
All right, Jessica, good. All right, so it's a dark brown golden nodular tumor. Um, Incidence is 1 in 2,000 to 205,000. It's usually unilateral and unifocal, and unfortunately, can metastasize to the liver and kill you. So, what would you be picking up in the history? So, as you realize, most of the other stuff didn't give you much that we spoke about, didn't give you much visual issues. Okay. But definitely here you're gonna have someone who is blurred vision, they have visual field effects, and what we saw before, we said this is an extra scleral extension, mean it's come through the sclera, and we can also see, come on, we can also see sentinel vessels. So usually the eyes give you a clue of what's happening. So look at this side of the eye, nice and clear, and over this side we see all these vessels. Then we look at the pupil and we realize that the pupil is nice and round here, but then the edges of the pupil are a bit straight here. And with the eye of faith we see a little mass, we see a little dark spot obscuring the light reflex. Okay. So and then, because as I said, because it can be presenting from the choroid level, you can get retinal detachment, you can see orange pigment in the retina, vitreous hemorrhage, and what is a pathognomic feature is that when you do an ultrasound, you get a this mushroom effect. So this is only seen in melanoma. So if you if you have a patient and you want to know, if you have this patient and you're not sure, you order ultrasound and you see a nodular eruption in the retina looking like a mushroom, you're like, yes, we're good to go. We know it's a uveal melanoma. So of course we're going to radiate, resect, enucleate is the exenteration if it's massive scleral spread, laser, cryo, chemo if we have metastasis. So see, it's not, as I said to you, the treatment you can easily figure out. You just have to remember, you just have to make notes as to what is where. Okay? So and then so that you know you know what words to say when the terminologies. Make sure you remember your anatomy. So now we're talking about iris tumors, and of course, everybody gonna say to me, Doc, how do I know that this lesion is on the iris and not on the cornea? Why is it on the iris? Because we can see, if we look here, we see actually the irregular, it's following the lines of the iris here, the pits of the iris, the radial muscles of the iris. Okay. So iris tumors, they're easy to see. It's a discoloration of the iris. It can either be partial or total. Um, a lot of times we see this, and the usual stuff that we say with the nevus, we watch it, we observe. So we take measurements. If we see if it's getting larger, it's not very aggressive. Usually seen in older age group. Treatment, exercise, enucleation, radiation. Um, we can either do a proton beam or a plaque to ensure that it's only the specific area that is receiving it. All right. Now, I'm not sure if you guys, I'm thinking that you guys did retinoblastoma, but you always have to remember retinoblastoma. Why? Because it's sight-threatening, it's life-threatening. It is a medical emergency. It's an ophthalmic emergency, so you can't miss it. All right. So we're going to talk about how you make sure you never miss a retinoblastoma. So it's a primary malignant neoplasm of the retina. It originates from immature retinal cells. It's the most common primary intraocular malignancy of childhood. It can present in children or infants. It's and it's autosomal dominant. Unilaterally, it's often unilaterally, but unfortunately, it can be bilateral. And but most times there's you can't pick up a hereditary trend, um, but in 40% it is. So you will oftentimes pick up pockets. So oftentimes you see pockets of retinoblastoma in certain parishes, and sometimes you have to give advice, try not have any more children. If you have any cousins, be be alert, because we've seen it in families and it is very devastating. However, it's not that they're not necessarily going to listen to you. All right. So this is important. It's an important slide. How are you going to pick it up? How are they going to present to you? How are you going to know that it's a query of possible retinoblastoma? So you're going to see a white reflex, or it might be a loss of red reflex. The child may present with strabismus, may have a red painful eye. You may see a retinal detachment. And when you order the ultrasound or the CT scan, the pathognomic feature is calcification within the lesion. All right. So if this is one slide you don't forget, this one it is. So if we look here, what it is that we're seeing here, what exactly we're seeing here, this is purely a retinal detachment that has come forward because the mass has pushed the retina forward. So you're literally seeing the blood vessels on the retina. When you see this eye is in trouble. This eye has got to go. But we also have to examine this eye to make sure that it's unfortunately not one of the bilateral cases. So treatment, chemotherapy, radiation, cryo, laser. No, unfortunately, okay, look at this beautiful kid here. You see the obvious leukocoria here. So every baby that you meet, you must do the red reflex. Okay? If it's one, it's just you just take up your ophthalmoscope and you make sure you can get that red reflex equal. This is what happens if it's not treated. This child is most uncomfortable. So definitely, you'd never want the child to get to this stage. You must pick it up before it gets here. This child is at risk of um, cranial spread and death. All right. So the last thing that we're talking about is not very common, but sometimes we may be the first to determine that a patient may have cancer. Oftentimes we see these non-specific lesions in the eye, and we don't know what it is. And you know, oftentimes we're like, I wonder if it could be. So, and then we send them off to get tests. So there's very non-specific lesions. These non-specific lesions, when you see them, you have no choice but to to investigate them. So it is oftentimes it's hematogenous. The incidence is 1 in 100 and 25%. So that's quite a bit. 25% is the initial presentation of the carcinoma. Most commonly, it's breast cancer in women, lung cancer in men. Um, so most times they come to you because they're having blurred vision. You see a melanocytic round to oval choroidal mass. At least this one it's this is telling something is happening because you see this dilated vessel here. But look at this lesion here. These lesions, you can't quite tell. Are you seeing correctly? Or you're not seeing? But yes, when you see these little lesions here, you have to send them off for testing. It can also be associated with retinal detachment. Of course, you want to treat them for whatever it is that they have. But sometimes, if it is really extensive, you may have to enucleate the eye. So, see, ophthalmology is important. We do save lives. See, didn't I save this lady from breast cancer? And didn't I save this child from not dying? See? Ophthalmology is not only surgeons save lives, we save lives too. Any questions? Okay, Melanie says she good. So everybody able to identify these lesions, make sure they never miss a retinoblastoma because they're going to remember the slide. Okay, most important. All right.
Hi,
And you'll be
sorry.
who's it? Melanie? Mhm.
Yes. Is it possible to go back to the iris? The iris, right?
Iris?
Yes. You were saying something. Yes, right. You were saying something about how you were able to identify if it's um on the iris or on. I can't remember what you were saying, but it's possible if you could explain that again.
Sure. All right. So if you look at the iris, the morphology of the iris, you see these little crypts. So you have the radial muscles, the radial muscles and the circular muscles, okay? The horizontal muscles. So what you're seeing, so okay, so here it doesn't tell you much, but when you look at the pupillary margins, you see that these borders are irregular. So of course, if you saw lesions like these, you'll be like, okay, you'll watch it. You can't quite tell. But when you start looking here and you're seeing that it's following the crypts, these little crypts that you see here, you know that this is suspicious. Something is happening here. All
Okay.
right?
Thank you.
Mm, yes. All right. So everybody's able to. So if you got this if you got this lesion, oops, if you got this lesion in the exam, you'll be able to describe it and be able to say your differentials and your treatment, right? Everybody should be able to handle that, right? Yes, definitely. Anybody not able to and not anybody not able to handle a lesion like this, can anybody not don't think that they're comfortable describing it? This is the time to say hello. Yes, me. Remember, we're gonna have to talk soon. So this is the time to talk. All right. So if you're all good, that's me for the day. I will see you all. I think I'm doing tutorial with you guys for diabetic retinopathy, and then I won't be talking at all. All right, guys. So that's it. That's it for me today. Take care. Be safe. Bye bye.